Now let me invite Dr. Sara Jacob for her topic, Traumatic Lens Injuries, How and When to Intervene. She's Senior Consultant at Giridhar Eye Institute, Cochin.
Good morning all. Thank you KSOS for this opportunity and Dr. Kalaimati for this opportunity. Traumatic lens injuries, how and when to intervene. Both open globe injuries and closed globe injuries cause a variety of lens trauma. We should be cautious not to approach traumatic cataract as a typical age-related cataract. This is because half of the traumatic cataracts have associated posterior segment damage, and the diagnosis of traumatic cataract is challenging in the presence of a hazy media. The cornea will be hazy, there may be hyphema, fibrin, and the pupil may be non-dilating. Overall, the classification can be done as a total cataract, membranous cataract, white soft cataract where the anterior capsule is ruptured, and a rosette cataract. The clinical assessment should include a comprehensive history regarding the mechanism of trauma, the force of impact, and if it is a mild trauma, there may be ectopia lendis associated systemic comorbidities like Marfan syndrome. Examination should focus on vision, pupillary reaction, and extraocular motility, increased intraocular pressure, AC involvement, vitreous involvement, and fundus involvement. Investigations: B scan when the media is hazy, CT scan to rule out a foreign body when you are suspecting it, and ultrasound, UBM, and swept source OCT may help to assess the status of the posterior capsule. Medical strategies can be tried. We have to control the intraocular pressure and intraocular inflammation. If it is a focal cataract close to the visual axis, we can monitor. If it is close to the visual axis and causing glare, we can give a trial of miotics. Subluxation of the lens can cause a new cylindrical power and the spectacles can be changed. Subluxation of the lens can cause uniocular diplopia and miotics can be tried. When will we decide to intervene? When there is decreased vision, when there is lens-induced inflammation or glaucoma, when there is capsular rupture with lens swelling, and when there is obstructed view of the posterior segment pathologies. So we will consider few challenges while dealing with traumatic lens injuries. Whether we have to go for a simultaneous primary repair and cataract removal or a staged approach. So the advantages of doing a primary cataract removal is that it prevents inflammation and raised IOP. It allows immediate visualization of the posterior segment. It allows early visual rehabilitation of the patient, which is very important in the young children with a risk of amblyopia. And also if there is vitreous hemorrhage along with lens damage, it acts as a risk factor for the development of proliferative vitreoretinopathy. And also definitely it will decrease the overall cost of the patient. Disadvantages are that we cannot truly assess whether it is a traumatic cataract because of the hazy media. The lens may not be truly cataractous, and this surgery, additional surgery, can increase inflammation. Operating room may not be always be prepared to deal with vitreous and cataract surgery. So this is a surgery being done. The primary wound repair is being done, and as the operating room was well equipped and there was not much damage, we went ahead with cataract surgery. This is a patient with open globe injury. Only the primary repair was done initially, but after 3 days, as the IOP was not getting controlled and there was total cataract and rupture of the anterior lens capsule and the IOP was not getting controlled, we went ahead with lensectomy as a secondary procedure 3 days after the primary repair. There is currently no definite guideline regarding this. A case-by-case approach should be made. The surgeon's experience and expertise, and most important, the available equipment and the readiness of the operation theatre, and then the patient-related factors such as age, lens status, and the presence of sonular weakness and vitreous in AC all will help to determine whether you have to remove the cataract as a primary procedure. The challenge too is that If the anterior capsule is ruptured, whether to go ahead with an immediate cataract removal or a delayed approach. So definitely it is better to go ahead with the immediate cataract removal if the lens matter spills into the AC. And also in pediatric cataract, where there is a high risk of traumatic endophthalmitis, if the anterior capsule is ruptured and the media is very hazy, it will be difficult to follow up the young child, and advancing traumatic endophthalmitis may be missed. But it can be delayed if the anterior capsule is compromised but there is no extrusion of the lens material. The visualization of anterior capsule with white cataract is difficult. We can use trypan blue, but if there is severe sonulopathy, this trypan blue can sweep into the vitreous and reduce the red glow. And also few case reports have suggested that it is better to use indocyanin green than trypan blue if the anterior capsule is ruptured, so that it will not stain the cortex. The third challenge is which surgical technique we should use. When selecting the appropriate surgical technique, consider the patient's age and the condition of the posterior capsule. In pediatric traumatic cataract, early management is essential because of the difficulties involved in examination, the severe intraocular inflammation which follows, and the risk of amblyopia, and the vitreoretinal adhesions are more pronounced in the young age, and it can lead to peripheral retinal breaks if you are exerting traction. Phacoemulsification, SICS or ECC can be done if the PC is intact. And if phacoemulsification in the event of vitreous presentation, we have to go very cautiously. First, we have to do vitrectomy to remove the vitreous from the AC. We have to use dispersive OVD to plug the area from where vitreous is coming out, and we have to do a slow motion phaco. Lensectomy and vitrectomy are definitely optimal when there is PC rent and vitreous loss. This is because the instrument cuts and doesn't pull, and so it doesn't cause any peripheral retinal breaks. The two options for lensectomy are anterior limbal and the posterior pars plana approach. The anterior limbal approach we can do if there is anterior lens dislocation. The pars plana approach is preferred when there is posterior capsular rent and posterior lens dislocation. The other situation other than traumatic cataract is when the cataract is subluxated. So here the rhexis is done and it is started from an area away from the area of zonular dialysis. Capsule hooks are placed. Gentle hydrodissection is done in the area away from the zonular dialysis, and gentle nucleus rotation is done, and phaco, in slow motion phaco is done, which causes less stress on the zonules, and the cortical aspiration is done in a tangential manner. And every time you withdraw the instrument, viscoat is injected through the left side port to prevent AC collapse. CTR is inserted and dialed so that the closed part of the CTR gives maximum support to the area where zonular dialysis is. The CTR is being dialed to the area of zonular dialysis. And a 3-piece IOL is injected into the bag. The fourth challenge is whether to implant the IOL as a primary or secondary procedure. Primary IOL implantation, the advantages are less chance of amblyopia, the synechia formation can be avoided, and closure of the bag can be prevented. Disadvantages are that difficult to do a correct biometry and keratometry, and IOL power calculation can be erroneous. The IOL opacification can occur secondary to the postoperative inflammation that occurs. Conditions in which it is not recommended is primary IOL implantation is not recommended is children less than 1 year, and where there is severe damage like severe inflammation, endophthalmitis, significant corneal damage, risk of AC rebleeding, inadequate capsular support, serious posterior segment injury, and increased risk of PVR. Secondary IOL implantation is definitely better in the case of serious ocular injuries because we will know the potential for visual rehabilitation after assessment and treatment of the associated ocular injuries. The challenge 5 is intraocular foreign body. Inert intraocular foreign bodies like glass can be managed by observation. Metallic intraocular foreign bodies have to be removed. They can be removed by lens preservation using magnet, or it can be more aggressively removed by primary cataract extraction and intraocular implantation. So here there is a metallic foreign body which is lodged just under the anterior capsule. Before doing cataract surgery, before removing the nucleus, the foreign body removal is attempted, but it is not possible. So after removing it with a micro forceps, it is grasped and removed. To conclude, selecting the most appropriate therapeutic approaches depends upon factors such as the patient's age, control of inflammation and intraocular pressure, condition of the posterior capsule, and other associated ocular damages. Proper preoperative evaluation and meticulous surgical planning are essential to achieve the best possible outcome.